A warm welcome to all of you from Cancer Control Alberta, Wellspring Edmonton, and Wellspring Calgary to living your best during the pandemic with advanced metastatic chronic or non-curable cancer, supporting quality of life through the cancer journey and approach to care. Our first speaker is Dr. Lyle Galloway, and I'm going to turn it over to him to do his introduction.
Okay, let's see. Have you got me?
We got you. We do.
Good. Stay on for a sec there, Sheena. Your audio was breaking up for me in the last 45 seconds or so. I'm just wondering, is my audio good? Was that just a phenomenon at my end, or is there something weird?
Yours is good.
Okay, good. Hello. My name is Lyle Galloway. I'm a palliative care physician in Calgary. And I'm just going to talk a little bit up front. So initially, Sheena and company asked a number of us about doing this talk. That was pre-COVID, I think. I don't remember exactly when. And we punted it around a little bit. And I think Dr. Watanabe from Edmonton had done it, a similar talk last year. So she said, Lyle, do you want to do it this year? And I said, okay, sure, that's good. And then COVID happened. And, I guess I had in mind when I accepted that this was going to be a Wellspring talk, which I've done a few of before. And for any of you who've been to Wellspring, you'll know that it's a cozy house-like environment that's entirely non-medical feeling, and and the little speaker room that they've got there where they can have, usually you get a dozen people showing up. So it's easy to do a talk because you can kind of show up and feel out the room and see what people's concerns are and then speak to those. And then the virus happened and we delayed for a bit and then rescheduled. And now there's, I don't know how many people are signed on now. That's a whole bunch of people. So more than would fit in that room at Wellspring. So this isn't exactly the original presentation I had in mind. And then they went and put pandemic in the title. Let's see. I'm just going to share my screen here. There we go. So, I said, okay, yeah, I can do July 9th, but I'm moving houses at the beginning of the month and my life is going to be totally chaotic. And I can't promise that I'm going to have any fancy slides or anything like that. And so the folks at Wellspring sat down and actually put together this beautiful synopsis of things that they felt or had heard that people wanted to talk about. And essentially I could have, I'll stop sharing. Essentially I could have just cut and pasted everything that they put into PowerPoint slides, but I didn't. And Krista, whose name I've put on this title sheet here now, because she actually made all of these slides. And then she not only made them all, but then revised them all, and then sent me a third revision. And so I think she probably just didn't trust me to be capable of sticking to the topic or something. So I'm going to try my best to respect Krista's slides here. I'm not a big PowerPoint fan, so I thought what might be most useful here, not knowing who was going to show up, and as I look at the list of people who are signed in, I know there's a whole bunch of healthcare workers here. Let's see, oh, Lisa Lamont's there. Lisa actually helped put together this whole synopsis too. Yeah, you healthcare providers can't hide. So a lot of this presentation is sort of introductory for people who may not have seen a presentation like this before. And I've been doing palliative care for about 20 years and have done this presentation or a similar kind of presentation a number of times. So I thought what I'd do this time is kind of just give a little bit of a different spin on it because I had all these beautiful slides to work from. And what I'll do instead is just sort of give my perspective as a palliative care physician, as I think about speaking to these slides. So I'm going to just launch in, but I want to give a big thank you to Sheena and Krista and everybody else on the organizing committee who did all this background work and got me organized and put up with me not responding to emails for weeks at a time. And here we are. So how's that for a title though? Living Your Best During the Pandemic. That part got added afterwards, with advanced metastatic chronic or non-curable cancer, supporting quality of life throughout the cancer journey and approach to care. So essentially that's the whole presentation here, live life to the fullest. And I'm just gonna talk around those points a little bit. The bit about during the pandemic, I was initially hesitant and said, you know, I really don't know a ton about coronaviruses or pandemics. So I'm not sure I'm the right person to talk to this, but I can talk about how it's affected our practice at our institution. And everybody seemed to think that was okay. But if you're here to learn about coronaviruses and you think that's what the subject of this talk is going to be, you're in the wrong chat room. Anyway, bear with me and we'll get to talking about that a little bit. The other thing that's not on this title is the word palliative. And that's something that is by design, I think. Here, I'm gonna pull up that screen again here. Hopefully that's not too irritating if I keep switching back and forth. The word palliative is an uncomfortable feeling word for a lot of people. And it actually wasn't originally formulated to be an uncomfortable word. It was supposed to be like a comforting word, I believe. It was coined by Balfour Mount in Montreal. It's a Canadian word, from the word pallium or cloak. So it would mean, okay, we're gonna give you a warm cloak to help make your life better as you go through this journey. Anyway, at some point it became associated with imminent dying and end of life and sadness and grief and bereavement. And it's an uncomfortable word. So, if you look at this title screen, our service under my name here is the Complex Cancer Management Service. So when we first came to the Tom Baker Cancer Center about almost 6 years ago now, we intended to essentially put in a palliative consult service like existed in all of the acute care sites and in the community sites and so on. And it was pretty clear that calling it palliative care in the cancer center rubbed a few people, at least, really the wrong way. And people were legitimately concerned about what would patients think of having the word palliative care in their cancer center. So we're the Complex Cancer Management Service, but that's just code words for palliative care. Essentially, we do pain and symptom and quality of life consultation throughout the cancer center. And it's not just for people who have incurable cancer, it's also for people who are going through curative treatment for cancer and are experiencing difficulties that are messing up the quality of their life or are struggling with meaning or whatever. And I know Kevin, who's speaking after me from the Cross, is going to speak a lot more to some of those bigger dimensions. I'll talk a little bit more about what I do, because I think a lot of people don't know what a palliative care physician does. Even the residents that we get through the program. So they've been through medical school, and now they're doing additional training in whatever specialty they're choosing. And they'll often spend 4 weeks or so with us in palliative care. When they arrive, they're usually entirely unprepared for what they're going to see. I think what they expect is that it's going to be a lot of really laid back, touchy-feely Zen people who give a lot of morphine and hold people's hands a lot and so on. That's kind of the stereotype of palliative care, and that our patients are going to be dying and look like they're dying. So, and the reality is it's much more interesting medicine than that. So I'm just going to talk around the realities of clinical practice in palliative care as I go through these slides, which speak to it a little bit more abstractly. And I've rambled on way too much, so I should probably start screen sharing and flipping through slides. It's weird doing a Zoom presentation when I can't actually see the audience or hear anything. So I'm just going to assume you're riveted here. So in my work, is, I'll talk about how I got here first a little bit, which hopefully is useful. I did med school in Edmonton. I graduated in 1992 and did a family medicine residency initially, and worked in family medicine for 7 or 8 years before coming back to U of C and doing a fellowship in palliative care. So my current work is at the Tom Baker Cancer Center, working as a palliative care consultant. And really what that looks like is pain and symptom management consultant. And often that's kind of how we introduce ourselves, because again, palliative care is a scary word for some people, and well, cancer is a scary word on its own. They both kind of feel bad, and if you put them together in a sentence, it's an especially nasty feeling sentence to a lot of people. To those of us who've been working in palliative care on an ongoing basis, palliative care actually is like a friendly word. When we're talking about, calling a palliative care provider in another city or whatever, you're going to get somebody who's kind of like-minded and sort of puts human values first as they do medicine focused on quality of life. So people often say they wish they found services sooner. And I'll talk a little bit more about that. Actually, maybe I'll talk about it right now. So in the cancer center, we see people kind of on a consult basis. So we'll get consulted by a primary oncologist, for instance, who's struggling or just doesn't have time in clinic to deal with a complex symptom management thing. In the majority of cases, that's pain. Sometimes it's nausea. Sometimes it's actually just being really freaked out about their diagnosis and the fact that it's not curable, and that their role in life is changing, and we can sometimes help navigate that. I remember one of the initial consults I did when coming to the cancer center was with an older guy. His daughter was with him. She's a lawyer, so she's very organized and came with a good list of questions, and it was pain essentially that we were asked to see him about. So I was seeing them with one of the pharmacists on our team, and actually had one of the nurse practitioners on our team we were again just starting at the cancer center at that point, so she just joined the team and wanted to see, okay, what does a consult look like? So we sat down and went over his pain concerns and came up with a plan to address those and to do some follow-up. And we covered more about sort of just his understanding of what his cancer meant and what stage it was at, and asked, do you want to talk about implications for, for prognosis, how long you have. Has anybody talked to you about that? And no, nobody really had. The focus had been on cancer treatment. So we talked about that and touched on advanced care planning, or the whole conversation around your wishes if you're not able to make your wishes known, which was actually really easy, because when you've got a daughter who's a lawyer in the room, she's used to knowing that those are necessary conversations, and that most people want to make sure that things are in place, but don't know how to bring this up with healthcare providers. So we covered that, and it's probably a, I don't know, 60 to 90 minute interaction, and kind of wrap things up. And his daughter's looking down her list of questions, and we apparently had covered most of them. She said, "Oh no, there's one more." Okay, so when should we be involving palliative care? And we all just kind of laughed and said, okay, so what we've been doing for the last 90 minutes is palliative care. And they said, what, really? And she said, I don't think I would have brought my dad to this appointment if I knew we were meeting palliative care. But honestly, this has been the most informative and useful visit that we've had since my dad's diagnosis of cancer. And it just, I don't know, it made it real that we can't just storm in and say, okay, palliative care is great and it's for everybody and helps everybody live better, because it does scare some people. So I don't know, we may have to continue to employ a degree of stealth, because I don't think the meaning or the unconscious meaning or feeling of the word is really going to change for people. And that was a bit of a ramble. So this is the reason that Krista probably gave me slides, is to keep me from going off on little tangents. I am now flipping on to the next slide. So one way of thinking about palliative care is that it's improving quality of life. And in many cases that centers around symptom management. Another way of putting it, and I like this. I don't know. I'd be interested to put your comments in the comment box if you think this is good or bad. Diane Meyer is a physician. She's an internal medicine and palliative care specialist in the States, who's the director of the Center to Advance Palliative Care. And one of her big interests is marketing and branding and so on, which is a new thing, and it's something I hadn't really thought about too much until I heard her speak about it. And since then, I realized it's becoming a big thing in our society. But she acknowledges right up front, okay, palliative care has got a branding problem. People associate it with end of life and with sadness and grief and whatever. It's not an empowering sort of thing. So her suggested way of talking about palliative care, she said, we match treatments to patients' goals. Full stop. Don't be talking about very end of life sort of stuff or whatever, because people are going to get confused. But essentially, this is my job, is to figure out what's important to people, and to my piece is as a medical doctor, so I get to kind of do the geeky lab stuff and the medicine stuff and that kind of thing. But just figuring out for this patient and what's important to them and the family that's around them and their understanding of what's going on and so on, what do we need to do to optimize their life from their perspective? And I think that's palliative care. Whether it's happening years before the patient's end of life, or whether it's happening in last days. So this is Camilla Zimmerman in CMHA a few years back, just kind of saying, what does palliative care mean to you? And here's some of the things. It's the care you receive when you're dying. So these are answers that she got when she was asking. It's all about keeping the person as comfortable as possible. You've reached the end of anything that can be of any help to you. That's kind of dismal. You're in a situation where somebody else has to take care of you. It's a place to die. And palliative care is often misconceived as a place. It's a discrete ward in the hospital, or it's It's the place you go when you don't have any more medical treatment available. I don't really know what it is. Here's the World Health Organization's definition, which is kind of weird, along with a stock photo of a happy family looking at pictures. Palliative care is an approach that, so this is something you'll hear a little bit, and it's in the title of this presentation. It's an approach. It's not like a system or a textbook of algorithms or whatever. It's basically a way of approaching people and illness that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. It's a really wordy definition, and I promise that's the last PowerPoint slide I'm going to read to you, because I'm not a PowerPoint slide reader. I'll assume that you can read those. It puts a lot of stuff in there, and they probably spent weeks fine-tuning that, and then this is the revision number 26 that we're seeing. But they tried to kind of put a whole bunch of stuff in there. Not sure if it's useful or not. So in the past, and this is the illusion that people sometimes have, is when cancer treatment ends, okay, then is when we should be talking about palliative care. It's something that exists along with cancer treatment. All of the patients that I see are receiving cancer treatment. This is a model that Pippa Hawley, who's a palliative care and internal medicine specialist in Vancouver, published a few years back. The previous way of looking at things was, okay, if you're gonna, let's see, can you see my mouse? I'm not sure. Sheena, can you unmute and tell me, do you see my mouse?
I can see your mouse.
You can see my mouse? Okay, good. So look at my mouse up near the top here. Imagine an older model that just has kind of a linear thing with time going this way. So the way the old conception of palliative care would have been is, here's your diagnosis, and then we treat, because we're trying to treat your cancer. And that means another line of chemo and another line of chemo. And then we run out of lines of chemo. And then we say, oh, we don't have any more treatment. And kind of there's this stop of treatment. And then we consult palliative care. And palliative care kind of takes things from there. So there are clear problems with that. And it's evolved over the last. So this is the latest graphical model of palliative care. If you can imagine these two overlapping triangles, disease management is the blue one, and palliative care is the pink one. So here is, we can imagine, this is the time of your diagnosis, and this is a cancer-specific talk, so we'll talk about this is your diagnosis of cancer. And at the beginning, disease management, so what can we do to treat this cancer, to slow it down, to cure it? Is often the biggest part of the focus. As time goes on, often what we see is the needs of patients not related to actual treatment of tumor cells tend to increase and become more predominant, and there is more need for care. So if we look at just the disease management piece, what does that look like? It's all of the things that you see here. And this is the business of cancer centers across the world, is treating disease and treating complications of disease and treating complications of treatment of disease and so on. Looking at palliative care, on the other hand, these are the kind of things that we'll often see. So pain and symptom management is a huge piece. And again, that's 90% of what I do at the Tom Baker Cancer Center is pain and symptom management for people who have cancer, be it incurable or not. It's also discussion about where are we going from here? Big picture stuff, how many lines of chemo are there left? Do you want to talk about how much time you've got? Do you want to talk about what happens if your liver disease progresses or whatever? The end of the road when disease management kind of ends is either where you've got your finished with cancer treatment and we've got no more treatment, and we're talking about survivorship, which is a whole field of supportive care of its own, with rehabilitation in many cases to kind of get back to normal or as close to normal as possible after treatment. The other possibility is that we're talking about end-of-life care, which would represent this piece of things here, and caring for families or loved ones afterwards is also part of palliative care. So what this model is hoping to show is that ideally these are linked. And that's what I see in my work every day. We sort of infiltrate every part of the cancer center, and people are happy to see us because we actually make their, so staff are happy to see us because we make their jobs easier, and patients actually are happy to see us as well. It's not like we're the depressing palliative care team that comes and wants to talk about dying all the time. We actually tend to try and talk about what is meaningful. What's been found in studies in the last 10 years or so, where they've actually looked at introducing palliative care early where possible. So when you show up, probably the landmark study, it's a slide that's hidden right now, was done by Jennifer Temmel in 2010 and published in the New England Journal of Medicine, which would be kind of considered one of the most prestigious medical journals around. So it was a bit of a coup for palliative care. It was probably a political move on the part of the New England Journal to some extent, to kind of say, okay, yeah, this is real medicine, pay attention, people. This is important. So what they did is they took people who were diagnosed with lung cancer, and basically the only stipulation, I think, was that it had to be non-curable lung cancer, so non-resectable right from the start, or metastatic right from the start. And rather than just doing regular treatment, which they did for everybody, for half of the people who were randomized, they introduced them to a palliative care practitioner early in the course of their treatment. And I'm not sure if it was like first visit, but it would certainly be like first few weeks, before your first chemo. And that palliative care practitioner kept in touch occasionally or as needed throughout. And it wasn't a big fancy intervention with a whole big team or anything. Essentially, it was kind of a little checklist of, here are things that people usually want to talk about in this situation and sometimes don't. And so at the end of the what they expected to see was that patients felt better and caregivers felt better, and that their experience of cancer treatment and living with cancer was better. And they did find that was the outcome of the study. But the other thing that they noticed was patients lived, was it 3 months longer on average if they were introduced to a palliative care practitioner early, rather than when they ran out of treatment options or got really, really bad symptoms. So that was one that made people raise their eyebrows a little bit and say, oh, okay, palliative care does not hasten death. In fact, it may delay it a little bit. So this is it's maybe a little bit of a complicated diagram that I'm not sure if I'm going to spend a lot of time on. What it's talking about, though, is palliative care isn't something that you're going to get just from a palliative care provider. Ideally, the majority of palliative care, the bottom of this triangle, that's the biggest base important part, is your primary care providers in the community or in the cancer center. This is your oncologist, your medical oncologist, your radiation oncologist. This is all of the nurses and the techs, and this is home care. This is your family doctor, very importantly. And palliative care basically means paying attention to what patients are experiencing, paying attention to the bigger picture, more than just scans and lab results and cancer cells, and addressing those and paying attention to them, and addressing what patients find is important for them. Specialist palliative care would be the tip of the triangle. So it's not the majority of patients who will require specialist palliative care. But when they do, and sometimes we're kind of in and out, we'll see them in consultation, maybe stick with them for a few weeks until things are stable, and then say, okay, back to Dr. Howe will continue to follow this from now. And most of our oncologists are fantastic at delivering palliative care in clinic. Sometimes we'll pick up people and things remain complex, beyond the level of complexity that that you can manage in a typical cancer clinic, and we'll continue to follow. And sometimes right from the beginning things are complex. But again, for the most part, palliative care is something that can be delivered by your primary care providers. It's available through the healthcare system. So as a patient, you're at the center with your family, with the family doctor and home care being the most intimately attached basis. And then here the other peripheral bits, like the Cancer Center, Foothills Hospital, Peter Lougheed Hospital in Calgary, Rocky View, acute care, acute palliative care unit in Calgary, that's at Foothills Hospital, unit 47, which is shared with oncology. It's a good model. It was initially born out of necessity because they didn't have enough beds to have a designated palliative care unit. So instead, we've got a ward, Unit 47, that's shared with medical oncology, radiation oncology, sometimes internal medicine. But it's an active medical unit where we also do our complex inpatient palliative care. And I really like the vibe of that, actually, to have oncology on and off the ward every day, and not sort of be this separate ward of the hospital that people look at with suspicion because it's called the palliative care ward or anything. Hospice, I don't know, I'm going to be talking way too long if I start to talk too much, but I'm just going to clarify. When you read stuff in the media or whatever, notice where it's coming from. If it's a United States publication, hospice means a different thing from in Canada. So in the United States, hospice basically means what we call palliative home care. And there's a lot more restrictions on it in the States. In Canada, hospices are generally freestanding facilities devoted to care in final months of life. So it's where people will live and be cared for 24 hours a day, and people are welcome to come and go, patients are welcome to come and go. But it's just a place that specializes in palliative care. So hospice in Canada, you could say, is a place. In the United States, hospice is not a place. Hospice is a service or a component of the medical system, very similar to what we call palliative home care, but also including access to specialist care as needed. Again, I'm going to ramble on a little bit too long, but in the States, you have to sign off of active cancer treatment in order to be eligible for hospice, which is I'll avoid swearing. It's a bad system in my opinion, because it basically sets people up for referral to palliative care late. The fact that you have to be finished cancer treatment and you're not going to be attending the cancer center anymore should not affect your ability to get good symptom control. This is the one pandemic slide I think I've got. So, and it's meant to be reassuring. Basically, we continue to do consults and to treat patients, and nobody's slipping through the cracks. A lot more of our work is tending to be by phone, and even new consults by phone or by Zoom. People don't want to come into hospital, and it's better now than it was a month or two ago, because hospitals had restrictions where you could not have a visitor if you were an inpatient, and then they're in the process of slowly lifting that. But for a period of time, nobody wanted to come to hospital for any reason, because you couldn't have a visitor, and especially if you were quite sick, nobody wants to die in hospital alone. home care has really stepped up and done a fantastic job, and they continue to work with us. We're in communication with home care every day in the cancer center as far as taking care of people, and then advocating for connection and for keeping people plugged into the system as needed. I think the other thing that the pandemic has done, so I can about this with one of our nurse specialists a couple days ago. This pandemic has, as you know, it's made us all feel like things are weird, and it's changed the way that we think about things and what we think about. It's 7:40. Okay, I need to really speed this up. And that's okay. It's really all I have to say. It's made people much more conscious. It's made us all, I think, more conscious of our mortality, and made end of life or dying of disease something that isn't quite such a taboo topic as it was 6 months ago. Everybody seems to be more willing to say, oh, okay, yeah, let's look at what I would be willing to go through for the sake of the chance of more time, for instance. And how important is quality of life for me? How important is being at home for me if I were so sick that that the end of my life might be imminent? Talking with some of the critical care, like ICU doctors, they're saying that people are much more open to discussions about what would your wishes be if this should get worse. And in fact, they're also saying, and as physicians, it seems much easier to engage in those conversations. That was something that often drove quite a few palliative care consults, was just, help, this family's really struggling. Can you help us out with discussion about what the end of life might look like in this situation? And that's become easier. And you have ICU docs more commonly saying, oh, okay, maybe let's ask this patient what they want before we put them on life support, rather than putting them on life support and then trying to figure out, should we have done that? That's the sort of thing that good palliative care means. And really for me, palliative care just means good medicine. That's why I decided to specialize in it, and it feels good. Oops, I think I meant to go back to screen sharing and I didn't. But I've only got a couple of slides left that I don't need to really spend much time on. These are the forms that everybody who's gone to the cancer center has seen some version of, where you tell us how you're doing. Those do get looked at, they don't get ignored, and they're becoming electronic so that they'll be even harder to ignore in some cases, I think, going forward. This is talking about advanced care planning and goals of care discussions. It's a super important topic, and it's one that's beyond the scope of this talk, but again, it's another part of what I do. There's lots of resources about palliative care on the web from Alberta and otherwise, and there's some take-home messages. So that was a hopefully not too long and rambling introduction to palliative care. And for those of you who are healthcare providers and have heard this presentation a million times before, I don't know, be interested in your comments. Is that a useful way to go through a presentation like this? Let's see, did I stop sharing? I think I did. I'm going to pass this over to Kevin. We're going to take questions after Kevin speaks.
All right, thanks, Lyle. All right, so I guess I'll take it over from here. Here, I'll just bring up my presentation here. Okay. So as Lyle said, I'm going to be shifting gears a little bit, and rather than talking about the physical side or the medical side per se, I'm going to be looking at the psychosocial and the psychosocial spiritual side. I'm a psychologist at the Cross Cancer Institute. I'm also an associate faculty member at St. Stephen's College, both of which are here in Edmonton. So I apologize if this gets a bit academic. I'll try to make it relevant, and certainly I'll do my best to answer questions at the end here with Lyle. So I think that to start off, it's important to look at advanced cancer and the cancer in general, and the form of psychospiritual or psychosocial spiritual distress that's associated with it, are very typically anyways. So I think first it might be trite to say, but of course, for most individuals, patients and their family members alike, the entire cancer trajectory can bring up a whole bunch of distress of a variety of different stripes in terms of the psychological. So we see depression, we'll see anxiety and anxiety disorders, worry, anger, resentment, guilt, a whole host of different things. Trauma, I'll speak to trauma here in a bit as well, is actually very common as well within the cancer experience. I think the estimates have it from roughly 20% all the way up to 40% in some studies of individuals with cancer experience some form of trauma, and in some instances, in fact, full-blown post-traumatic stress disorder. So I think it's really important to first honor that and really look at the fact that this is serious and that we need to consider the psychological and the spiritual and the social ramifications of cancer. And certainly as cancer persists and we move into the advanced stages or palliative stages, which Lyle kind of highlighted, does not mean that treatment is necessarily over. One of the big pieces that often comes up, and I certainly see this time and time again, and we see this in the clinical literature as well, is that many of the forms of distress that patients and loved ones report is often linked to what is perceived as a kind of loss of some aspect. So loss of one's functioning in the world, loss of one's identity, or loss of one's self. So we also see loss of physical functioning. Of course, perhaps you were used to be able to engage in certain activities and now you no longer can. Loss of social roles, loss of vocation, loss of income, loss of autonomy, loss of independence, your ability to function on your own in the same way. Many individuals report a loss of dignity. They perhaps need individuals to help them in ways that they didn't before, and now they feel in some way that this has eroded their sense of self-esteem or self-worth. A loss of identity. I used to do this, I used to be this, and now that's been stripped away from me because of either the treatment itself or the cancer or some other aspect of the cancer trajectory. Loss of an anticipated future. Many patients, of course, they have these plans, they have these anticipations of what they're going to do in the future, what next year will bring, what they're going to see, etc. And now that future horizon has been drastically cut down in some manner. And then, of course, the loss of hope, the loss of meaning, or loss of sense of purpose in life. And so, again, this is not the experience for everyone, but this certainly seems to be a common theme for many individuals with cancer and, of course, loved ones as well. So that's where we start in the distressful aspect. But the good news, of course, is that there is hope here and that there is a trajectory to developing psychospiritual or psychological well-being. There is a way forward. One of the things that we often see is that, again, for patients and loved ones, that the cancer experience being eroded by a treatment, which can be devastating to the body, the effects of the cancer itself, the impact on social functioning, all those losses can put one into a crisis state, a crisis of meaning. The normal experience of what they anticipated life to be and who they anticipated they were has now come under question and no longer makes sense. There's no longer coherence in living. And so, although that's very distressing, a crisis can also lead to profound reattunement with oneself, a deep sense of self-reflection and new perspectives on life, new priorities, new reorientation to a way of being in the world can come about through this crisis. So there can be a silver lining through this breakdown. It's as if we're peeling away the layers of an onion as we get to the core of who a person really is and what really matters in their life through the stress. And so in the literature, this is sometimes described as a transitional event. With cancer, someone enters a liminal state, a state of neither being on the first shore nor on the shore they're trying to get to. They're in between and trying to get to the other side. And if one does, it can be a positive event. And so in the literature, this is actually now being called stress-related growth or post-traumatic growth, or a form of transcendent growth. And I'll speak more to that later. And some of the pieces that we see, some of the possibilities that can come out of really wrestling with one's existential condition, with meaning and purpose in life, and all these kind of things that are called into question along the cancer trajectory. We can see a deepened respect and a deeper importance on interpersonal relationships in one's life. An enhanced appreciation of life, a different way of looking at life. An increased sense of strength or resilience can also be found in this crisis. Psychological or spiritual growth and maturation in this way. And changes, of course, in life direction. Perhaps old pursuits that one was engaged in no longer seem to have any luster to them anymore, and we completely change into a way that's much more meaningful or value driven. So there certainly are some positives that can come out of this experience, and there is a way forward. And so we want to start there, but I think it's important also to look at how do we get through them? How do we get from that first shore to the other side? How do we get to the other shore of psychological and psychospiritual well-being? Well, in a kind of summary of Dante's Inferno, when Dante asks Virgil, you know, how do we get out of here? He's afraid, he's entering hell. And Virgil essentially says to him, the way out is through. And unfortunately, or perhaps fortunately, a lot of the time when we're trying to contend with psychological dynamics that have arisen as a result of the cancer experience, it means that we have to really kind of go into it. We have to face it, explore it, process it, metabolize it, and then come out the other side. And there is a pattern to this. There are ways of doing this, and certainly we'll see there's patterns with loved ones, and certainly with psychologists like myself and other forms of psychotherapists and counselors, which I'll also speak to. We aid this process, we aid this journey. So I see my role as functioning something like Virgil. So I mentioned trauma earlier, and what trauma is, it's being overwhelmed. There's some experience that comes to you, that hits you, and you can't just readily make sense of it. You can't just keep going on with life the way it was. Something is radically shifted, and now there's a struggle to make sense and to integrate that into one's life. Trauma, in fact, means wounding. It derives from the word to be wounded. And so, as I mentioned, this wounding is an experience of loss, typically, and very, very frequently. So again, there's some part of oneself, one's life, one's identity, one's previous functioning, and one's way of understanding and relating to the world, which has now been severed or lost in some way. And so, of course, this is associated with grief. Now, normally we think of grief when we've lost a loved one, but it's not only associated with the loss of a loved one, it's associated with the loss of functioning of any kind. And in fact, various psychoanalysts have posited that the entire function of psychotherapy and of counseling is to help an individual mourn a loss that they are unable to do otherwise. And I think that's a very interesting way of actually looking at what our role is as counselors. So there's this grief, there's a sense of being lost due to the loss, a sense of crisis, meaning has been disintegrated. And so in order to heal, and the origins of the word heal are actually rooted the same as the word whole, and so it means to be made whole again. And so we mean not in the sense of being brought necessarily back to physical health, but back to a sense of wholeness. There's a great paper, I think, also in the New England Journal of Medicine, an older paper from 1982, which really speaks about this, this notion of healing is not necessarily being cured, but it's coming back to wholeness. And so psychologically, spiritually, physically, etc., we're looking at how do we facilitate that. And really it means that we must adapt or accommodate to our reality as it is now, to look honestly and squarely at our at our situation. And what this means is, in some way, letting go. It's a letting go of the old normal, and it's finding a way then to create a new normal. And that's really what this process of grief and mourning is all about. And again, not strictly in the sense of losing someone, but more broadly. So healing then can be considered, again, at least in a psychosocial spiritual sense, as the restoration of meaning and coherence in life. And so one of the ways that we navigate through this is what's being called the dual process model. And what this involves is first the loss orientation. And this is typically the really difficult part, the part that we all naturally struggle with. We don't necessarily want to face the cavern within our mind. We don't want to look at the darkest parts and darkest corners of ourself and our experience and of our reality and say, yes, that is true. And yet one of the principal components, I guess, of psychotherapy and clinical psychology is exposure therapy. And it's this notion of whatever it is that you don't want to face and encounter is something that very likely you should, in fact, be facing. And that is, again, the way through. So the way out is the way through in that sense. And so it's really reflecting on what the loss is, what it's meant, and what is no longer present in one's life. And then, of course, we vacillate to the other position, which is known as the restoration orientation. And this is now where, once we have begun to let go and reflect on this loss, we can look at life and go, okay, well, what now? How do I live most fully, most meaningfully now, given the parameters of my life as they exist, when I honestly and truthfully look at them? And it's a difficult thing. And yet this is what allows the restoration of meaning. This is how we come back to a sense of wholeness again. So we vacillate between these two positions. We can have days where we're mourning, where we're grieving, where we're depressed and dejected and anxious about life, and in a state of existential despair, perhaps, about what has been taken from us, about the unfairness of fate, which is certainly a term that we see come up a lot in existential psychology. But then also looking at our life and going, okay, well then how do I live in the face of this? Albert Camus is a famous existential philosopher, and he speaks to the myth of Sisyphus. And Sisyphus, it was condemned to roll a rock up a mountain, and then every day the rock would roll down, and you'd have to roll it back up the mountain again. And Camus says, you know, this is us. We are all a Sisyphus. We all have our boulder that we're going to roll every day, and we're going to have to roll it again the next day. And Camus says the key here is that you must imagine Sisyphus smiling. And so this is idea, how do we look at our fate, which we had no power over, we didn't control, we didn't choose cancer. How do we look at that and say, yes, this is my reality, and smile? And it's not an easy thing, and yet this is the goal, and it is possible. So again, as I mentioned, this is that acknowledgement, that accepting, that looking square on at what is. And the key then is that is precisely in letting go and accepting and chewing an experience by having an experience, by allowing it to wash over us. It's a term we might call catharsis in psychology. By really having our experience, then we are freed of it. And then we can begin to look at reality as it is and begin to heal and cohere back again into a sense of meaning. So steps along the way, how do we do this? Well, self-compassion and mindfulness, which are very closely related constructs, can help us to do this. So naturally, as I mentioned, of course, we want to resist painful thoughts, painful emotions, painful sensations. Of course, we don't want those. And so it's understandable that we don't want to face them, that we turn away from them, that we suppress them, deny them, and in other ways, don't look at them, avoid them. And yet it's important to, of course, as I mentioned here, in order to heal. And so this means that we grant space for our suffering. It means that we say to ourselves, yes, I am suffering. Yes, this is terrible. Yes, I am horrified. Yes, I am sad. Yes, I am despondent. And that we allow that. And we say that, yes, this is okay. It is okay to feel this way. And this is what self-compassion is all about. It's being open, sympathetic, and empathetic to ourselves and to our existential reality. The word compassion, the etymology of the word compassion means to suffer with. That's what the word compassion means. So to have self-compassion then is to be with oneself in one's suffering. And it's very, very difficult to do. Very often we're more used to having compassion for others and sitting with them perhaps in their suffering. But are we really willing to grant ourselves the space to sit in our sadness and our sorrow or despair, our grief? And then say, yes, this is okay, this is true. And then from there, from that acknowledgement, then begin to heal. And so this ties into mindfulness. And mindfulness is certainly a buzzword these days. It's often misunderstood as just simply a relaxation exercise, but it's actually far from it, in fact. Because what it involves is a non-judgmental, open, receptive, surrendering stance towards whatever arises within the field of one's mind, the field of one's consciousness. So whether it's a sensation of physical pain, whether it's a thought that it involves fears about the future, whether it's an emotion of sadness or anger, whether it's emotion of happiness or joy, it doesn't matter. It means standing back from it and just allowing it to be present, allowing it to occur within our mind, within our conscious field. That's what mindfulness is. And one of the key pieces with mindfulness practice is that it's observing whatever is going on in your mind. Again, thoughts, feelings, images, physical sensations, all of it occurs within your mind. All of it, right? It's observing it, labeling it, and recognizing that it's an experience you are having, right? And it's not an experience that you are. So you're disidentifying from the contents of your mind. In acceptance and commitment therapy, this is known as self as context, recognizing that you have experiences, you are not experiences in some sense. And certainly we could dive into that in terms of Buddhist notions of you can dissolve the self entirely, but that's perhaps getting beyond this talk. One of the good metaphors that we can use is watching the contents of our mind, watching our thoughts and feelings as if they were leaves passing on a stream. We're standing on the riverbed or on the creek bed, stream bed, and watching each of our thoughts arise spontaneously in consciousness as we don't have control over them. We don't have control over the emotions that arise. We don't have control over the sensations that arise. They're just there. And so our job is to stand onto the shore and watch them go by and recognize that another will go by. Current thoughts, in fact, or current estimates of how many thoughts and emotions and experiences arise in consciousness a day put it at around 60,000. So that's how many are just this constant stream, this never-ending flow of consciousness, the river of consciousness, as William James, who's a famous American physician, psychologist, and philosopher, put it. So we looked at self-compassion, mindfulness, and now let's turn to compassion and social support, which is certainly one of the areas that's been impacted by COVID and this pandemic and the lockdown that's accrued as a result of it. One of the things that the literature is extremely clear on is that this process of having our experience, of mourning our experience, of feeling it, metabolizing it, digesting it, and then being able to let go of it, to move on to the next shore, that this is facilitated by relationship. And now that's what my job is all about, is to form that relationship. But it doesn't have to be with a counselor, it can be with loved ones. It's the context in relationship that we heal, that we're seen by another, and that we can move forward. The literature also shows us, and certainly my clinical experience shows, that patients very often do want to discuss perhaps their darkest fears, and also their greatest hopes, right? As Lyle said, there's much hope to be seen here as well. There's much joy and to be lived in life, even in the advanced stages or even in the palliative stages. So I know right now I'm focusing on this, but I'll get more to the other shore in a moment. And patients often want to focus on or bring up these questions and these thoughts and these struggles, but they often struggle because they don't know how it's going to be perceived by loved ones. They're afraid to burden them. They're afraid to broach it. They say, I really want to talk about it, but this is heavy, and every time I do, maybe they kind of have this fear come into their eyes, and so I just don't, and yet I want to. And so I think that's important that we recognize that, and certainly for those of you out there that perhaps are loved ones of someone that's currently going through cancer, something to consider. So what that means then is, if you are a supportive loved one, striving to show that compassion, striving to show empathy, to really allow that individual to have their experience, to express it, whatever it is, and be with them, to hold them in their experience. And again, it's that suffering with, that's what compassion is rooted in, that notion of being with another in their suffering. Accepting it, not trying to say, okay, you know, it's going to get better, whatever. And so this is one of the things that constantly comes up. One patient of mine remarked to me, and it's always stuck with me, which is this notion of, you know, the loved ones in my life, I know they mean well. I know they want me to be happy and they want me to do well, but I remember she said, was this tyranny of positivity. They don't let me be sad. They don't let me be despondent. They don't let me feel that too. They are only saying, cheer up, you're going to beat it, you're going to get through, it's going to be okay. And again, that has a space too. Don't get me wrong. There's absolutely a role for positivity, encouragement, but we also need to honor the side of holding. And that's where individuals typically get stuck. It's not on the encouragement to restore one's life, but it's usually on that side of holding and processing the loss of what was. And on that note, we also have to look at informal caregivers and loved ones. And it's important, it's very, very critical that we also acknowledge and look at the distress that they face as well as a result of this. You know, cancer is an individual experience, but it's ultimately a family affair in greater or lesser degree. And so many, many people can be impacted by the fallout. And informal caregivers are people such as a spouse or a child or whoever it might be in one's life, a parent that's taking on this role of an informal caregiver. They're now perhaps doing some basic, almost nursing type duties at home, etc., whatever it might be. They're taking on these roles and these duties, even though they weren't trained to do that. And what the research shows is that these individuals are often in need of much psychological and spiritual support themselves. There's a whole host of issues that are associated in terms of anxiety, depression, sleep difficulties, fatigue, and poor immune functioning as well has been associated with informal caregivers. So I think we have to look at that, and we have to encourage, very importantly, that these informal caregivers and loved ones take pains to engage in self-care and to draw their own healthy boundaries so that they continue to function in the way that they want. One of my patients once remarked to me, you know, Kevin, at some point I realized that you can't pour an empty cup. And so there was this notion that they can no longer give of themselves if they have nothing left to give. And in order to continue to care for their loved one, they had to take that time for themselves to replenish so they could continue to go on. And I think that also has to be acknowledged. So, okay. So if we get then to the other shore, we've now arrived at the other side of developing a greater quality of life, a greater sense of psychospiritual being. And these are intimately tied together. And the research is very, very clear on this, that if we want to maximize quality of life for individuals with advanced cancer and the palliative stages of cancer, then we have to look at psychospiritual and psychosocial well-being. And there's a number of facets here that I want to speak to. One piece that really comes out in the literature is prognostic awareness. And that speaks to that notion of really looking square on at what one's reality is as much as that's possible. And of course, there are many unknowns with cancer. We can't say for certain how something will go or how it won't go, if there will be some kind of change in the prognostic course. Of course, that's the case. And yet acknowledging it as much as we can then allows us to live most freely in the present moment, because we're not necessarily wondering, okay, you know, how long do I have left? Is there going to be a recovery? Is there still going to be treatment options, etc.? We're able to look at it square on and then go, okay, what is an authentic way of living given the parameters of my prognosis? Coping, this is a term that we hear a lot about. The two most positive forms of coping are active coping, which is where we're actively in the world looking into our treatments, we're We're actively looking into what we can do in the world. If our functioning's been limited, we're saying, okay, how do I restore it in other ways? And emotion approach coping is actively allowing ourselves to process and have emotions. And these are in distinction to avoidance coping. And avoidance coping is we all know that the classic example of avoidance coping is substance abuse, of course, which is using an agent to avoid experiencing reality. But there's many ways in which we can avoid looking at our reality as it is. And avoidance coping is associated with worse psychospiritual well-being. Relationships, as we already mentioned here, that's a really key piece, is having people. And again, unfortunately, this is one of the areas in the time of COVID that has really been impacted. And the research shows that this is one of the key variables. And so it really is a shame. We're seeing this certainly in my practice. We're getting more referrals in with people in a more acute state because they're not able to see individuals or loved ones necessarily in the same way anymore. Empowerment, which means trying to find some way in which one can exert their independence. And very often a lot of that has been taken away. And so it's looking and saying, well, what can I do? What do I still have that I can offer? In which ways do I have a sense of autonomy? And that's related to dignity as well. Meaning and hope in life. Of course, these are very large constructs. It's looking at our existence, looking at our life story. We often talk about our life as a narrative, looking at our life as a novel even, and saying, you know, what is the meaning of this story? And even if it's perhaps cut shorter than I would have anticipated or maybe would have hoped, what is the meaning that I'm going to take away from this? What is the legacy of this life? And self-transcendence, this is a component I'll speak to a little bit more in a moment. But what this is finding yourself in a sense of connection with something larger than you. And whether that's God, nature, a higher power, the universe, whatever it might be, is very, very important as well to finding a sense of psychospiritual well-being. I'll also speak here to some of the dimensions more broadly. So this is kind of a quadrant model. One of the ways that we look at mental health and wellness is what we call a biopsychosocial spiritual or biopsychosocial existential model of wellness. And so these are some facets that if we examine them, we can strive to maximize our well-being. So at the biological or physical level, of course, we know that exercise, healthy nutrition, sufficient sleep, and rest are all associated not only with physical well-being, but also with how we are doing mentally. Proper sleep is particularly important. That's when our neurotransmitters are replenished, and that's so critical to feeling emotionally stable. The psychological quadrant here, mindfulness and mindfulness practice, other types of meditational practice can be very useful. Trying to find flow states, which is experiences where you feel that you've kind of just melted in or you've been absorbed into the experience, whatever it might be, whether it's listening to music or maybe it's working in the garden, those kinds of things where you kind of lose yourself in them, creativity, etc. Fostering positive emotions, gratitude in particular, finding space for that has been shown to be associated with a whole host of benefits for well-being, and being flexible psychologically, not shoulding, not musting, not saying that things have to be one way, but just being flexible with ourselves and with our reality. In the social quadrant, of course, taking time for relationships, which I think many of us are really thirsty for and yearning for more than ever, perhaps right now, and that's what's really been brought home for a lot of us. Boundaries. This is a term I mentioned, but many of us struggle with saying no to things. We take on too much, and we have to be willing to say, no, you know, that's too much. I need time for myself. So just as much as we need to have social relationships, we also need to be able to step back from them. Relational intimacy is having connections where we do feel that we can speak about the deepest parts of ourself with somebody and that they will be heard and accepted for what they are. And physical intimacy, for many people, having some form of physical intimacy, being touched by someone, being held by someone, having sexual contact with someone, if that's in one's life and one's wishes, those are also associated with well-being at the social level. And finally, the existential or the spiritual level, which I think of all of these is the most misunderstood, and so that's why I'll speak a little bit more to it. This really means looking at your experience in a way that is unique to us as humans. We are the only species, as far as we know, that can look back on ourselves and know that we all have a timestamp on our life, that all of us will one day, sooner or later, come to the end of our time here. And that means that we have to orient ourselves towards life in a way that no other animal, again, as far as we know, has to. And to live with existential well-being or with spiritual well-being is to live an authentic life, a life that is most true to who we are, given our limitations, given the cards that fate has dealt us. How do we live most truthfully and honestly in the face of our existential predicament, which is that we're here as human beings on this planet in the middle of the Milky Way, in this nondescript corner of the galaxy? How do we make sense of that reality, this immense cosmic reality? Well, we have to live authentically and meaningfully. And so looking at our value systems, orienting our values to what actually matters to us, maybe re-examining them, pursuing meaningful activities that are derived from that, and then pursuing self-transcendence. And so this is the slide then that I'll finish off with. I just want to speak more to this notion, because this is, I think, very important. The literature shows that in palliative care, this is one of the most important variables in terms of maximizing quality of life as one comes to more later stages of an illness trajectory in particular. And so at its core, when we look at the psychology of religion and the psychology of spirituality, we see that they involve a sense of transcendence, or at least the direct experience of it. When we strip aside any dogmas that might be associated with religions, any belief systems, which certainly have their place and their value for individuals, should they, the experience of religiosity or of spirituality often involves this self-transcendence. And so, as I mentioned, it's this sense of overwhelming connection or sense of oneness and unity with something that's beyond ourselves. Is this sense of belonging to something that will transcend our personal existence, our personal life. So again, this can be religious or spiritually mediated. Maybe it's a connection with God or a higher power, that kind of thing. But it doesn't have to be, and that's very, very important, is that this can be secularly mediated as well. And so individuals find this through connection with nature, with the universe, with the cosmos, with past or future generations of humans, that kind of thing. We can find ourselves included in a much larger frame of reference than just our individual life. And when we find that sense of identification, when we find our sense of openness to a perspective much greater than ourselves that will transcend our individual life, we can come to a place of profound acceptance, serenity, and equanimity in the face of the end of life, in the face of death. And certainly the research shows this, that even when we adjust, which is fancy statistical ways of when we get rid of all the other variables that might contribute to well-being and we control those, we still see that this variable is central to predicting well-being, particularly as we near the end stages of our life. So just a quick plug then for what psychosocial and spiritual services are available in this province here. Well, first, it's important to emphasize that the research is very clear. The counseling services in the cancer setting are overwhelmingly positive, and you don't have to have a psychiatric diagnosis or a psychiatric condition to benefit. So that's, I think, often a misunderstanding that a lot of patients that I see that have at first is that, oh yeah, but I'm down, I'm whatever, I'm blue, but am I really depressed? And they might be, but they don't have to be in order to benefit. And I think that's important to emphasize. And then that also goes for family members as well. The Tom Baker down in Calgary, of course, they have psychologists and social workers in their departments. And then up here in Edmonton at the Cross Cancer, we have psychologists and social workers, and we're also so fortunate that we also have some spiritual care counselors that I think are a critical part of our team as well, that I wish that Tom Baker would be able to get some funding to have as well, perhaps in the future. Currently, I'm not exactly sure what the Tom Baker is doing, but our outpatient services here in Edmonton are offered via phone and Zoom. And so what that means is actually that we are able to meet with patients all over the northern part of the province. So I have a variety of patients that are from, say, Fort McMurray or Grand Prairie now that I'm seeing that I wouldn't have been able to see before. So it's been kind of one of these silver linings to the COVID situation, is that it's pushed forward these digital forms that we're using right now, and so that's a positive. So if you are in Calgary and you're interested, or if you're in the southern segment of the province and you want to inquire into what might be available, I certainly invite you to call this number here, which is Psychosocial Resources, and then here in Edmonton at CCI, our Psychosocial and Spiritual Resources Department, and that's our number there. So I don't need to go through references unless anyone's interested. Certainly I can go through that. But yeah, so that's it there. I hope that I didn't bore anyone too much with that, and that was in some way instrumental. But I'll pass it over at that point, and I guess I just want to thank Sheena and Nikki and Janice and everyone else at Wellspring for having me, and for Dr. Galloway for his talk as well. So thank you.
Thank you. I hope you can hear me okay. Dr. Galloway, we'd invite you to turn your camera and your mic back on if you're still out there. There you are. I would welcome anybody to bring forward any comments or questions for our speakers. Now's the time. There is a note here that Calgary's palliative care team also has a spiritual care counselor. Do
they? Oh, excellent. I was in the impression that they did not currently have one at this time, but that's tremendous. That's news to me. So that's
Your impression is correct, actually, Kevin. So in the cancer center, we don't have spiritual care anymore.
Okay.
We do have a spiritual care provider working with home care.
Okay, I see.
And I guess, yeah, so there still are spiritual care providers in Foothills Hospital who, who serve
okay, not in that department itself currently.
Home care as well. But yeah, Tom Baker does not have, in Calgary does not fund that.
Thank you for the clarification on that point there.
But yes, it's important and we'd like more.
So we'll keep watching the chat to see if anybody has any more questions. Just to summarize, Kevin asked the question, what can I do? And so really the take-home message for this evening is what we offer is still available. So please reach out. Pain, symptom management, palliative care around symptoms and struggles, counseling, groups of support and programs available to you, and a community of people going through a similar thing, and during the pandemic. We at Wellspring are often saying cancer is not canceled, unfortunately. I also, so you guys, we have been building this plane as we've been flying it, I think as the whole world has been. So we're learning as we go. And to my learning, one of them tonight is that my land acknowledgement was local and not provincial. So my apologies. And so I would like to acknowledge that we are on traditional territory in Alberta of the many First Nations, Métis and Inuit whose footsteps have marked these lands for centuries. Wanting to share that coming together to offer you this information tonight through this Living Your Best event, we did not want to wait. We know at Wellspring Calgary that 25% of the people that we serve that are patients are living with a cancer that may never go away. And we know that many of you are living with this diagnosis, and that people are living longer with this diagnosis. There are better treatments. We know more about cancer today. We didn't want to wait to connect and share this important information with you. And we all came together to put together tonight. So I just want to say a huge heartfelt thanks to Dr. Galloway and Kevin St. Arnaud for being here for all of us. Oh, I see a question, my friends. So, if someone would like to consult with complex care, how do we initiate that? Is a referral needed from our oncologist? Can we ask for it?
Where are you asking from, Tracy? Actually, maybe I'll speak to that in general. I guess I know from Calgary. Okay, but that's a question I can answer. So yeah, most of our referrals come from oncology. I think it's good if your oncologist is aware of the referral anyway. We do get calls from, say, the nurses in the radiation therapy day room who say, this guy really needs your help. Generally, they'll have quickly run that by the oncologist first. And again, we don't like to impose ourselves and kind of take over aspects of care that are being dealt with in primary oncology clinics. So, but yeah, we'll get referrals from wherever. You can definitely ask for it, and please do so. That's in fact probably one of the messages that we should spell out, is this is something that you can ask for. The quality of primary palliative care that you will get in the cancer center is to some extent dependent on which clinic you're in. And even within, say, all of the lung clinics, to pick something, the way that oncologists approach palliative care is different from individual to individual. So if you're finding that there are things that are just not being covered or whatever, it's absolutely fair to say, how would we get involved with palliative care? We're doing more work as time goes on to try and actually incorporate early palliative care into cancer treatment. So currently there's it's a research project, PACES is the acronym, Palliative Care Early and Systematic, that is looking at people with advanced GI, gastrointestinal cancers, so like colon cancer in particular makes up the bulk of those. And getting in early. So for instance, as soon as the person is off of a first line of chemo because they've progressed on it, the trigger for a referral is automatically made. But one of the other triggers is patients just asking, can we do palliative, could I see somebody from palliative care? And in a future world, that will become a much more normal thing, I think. As people realize, okay, this is another, it's not an alternative to the cancer care that I'm receiving. It's another layer of care that can be added to my care if needed. Hopefully did that answer the question, Tracy?
Yes, she says
Great.
thank you.
Good. So yeah, if you talk to your oncologist or the clinic nurse for your oncologist, they will be totally familiar with how to make that referral. As well, I guess I'm just going to put this out for people who may not be attending the cancer center. So for instance, perhaps your cancer treatment has ended and there are no more lines of anti-cancer treatment, or you've chosen for quality of life reasons or whatever not to pursue that fourth line of chemo that has a 5% chance of any response or whatever. If you're not being seen at the cancer center, and how do you access palliative care in that case? Palliative home care is something that maybe I'll just mispronounce anything I try and say, dispel any misconceptions about. Often when people are offered palliative home care, they'll refuse if it's saying, would you like somebody from palliative care to come to your home? People often mistake palliative home care for somebody who needs to come by your house to change dressings or to help you have a bath or whatever. And many people living with advanced cancer actually don't need care in the home, or they've got really good in-home care living with them. But palliative home care, I would look at it probably as the best connection to the healthcare system that you can have if you're living with advanced cancer. And you can self-refer to palliative home care if you used to be able to flip to the back of your yellow pages, but that doesn't exist anymore. Or maybe it was white pages. Look on your browser, and if you just go like Calgary Palliative Care, it'll give you a number. The central number is 403-955-6299. Patients can self-refer. You can self-refer your neighbor. You can refer your mother, and they'll just kind of suss things out and say, okay, is this a situation that we should be getting into? And they'll pull, if it's your oncologist that they need to talk to, they'll talk to your oncologist, to a family doctor. They'll keep them in the loop. If they need to talk to a palliative care specialist, they'll talk to me if I've been involved, Tom Baker, to at least get some background, but there's consultants throughout the community as well that we can pull in as needed. So yeah, it's much bigger than just accessing it through the cancer center.
I'm going to read out this question from Jessica Lyle. I think this is for you. Thank you for this event. It was very informative. We found out last week that my mom progressed on her treatment. That's two second-line treatments that failed since January. Her oncologist said that we will just do symptom management for now when she's ready. Since you described the new model that doesn't have palliative care entering when treatment is ended, I feel anxious now that it's already late. And then she has another follow-up saying, my question is, why do you think her oncologist waited? And how quickly can we get in to see you in Calgary?
Yeah, I could only speculate about why. I think, again, there's a real spectrum of integration of palliative care across different settings and across different clinics even. So again, just to say lung clinics, for instance, some oncologists will tend to pull us in earlier, even when symptoms aren't as prominent, just to sort of say, we know this is progressive and there is going to come a time where you don't have another line of chemotherapy. And I'd like you to meet somebody else who works on our team. And generally that's a reassuring thing for people. If people are asked, do you want to see palliative care? Most people will say no, because to many people that means I'm giving up, or I think my oncologist is going to think less of me, or give me poorer care because I'm seeing palliative care. And so that's certainly not the case. Some oncologists still have that old model in mind as well, where palliative care is something that is pulled into the picture at a late stage when there is no more cancer treatment. And that's gradually changing. So it might just be some individual difference there. I'm not sure about the specifics of this situation. How do you get to see us in Calgary? I guess if you're not currently attending the cancer center, or your mom isn't currently attending the cancer center or having ongoing treatment, it's not my team that will be involved, but there is a palliative care team in the community that would be happy to get involved. And again, that looks like a referral to palliative care. And you can self-refer if you want to involve your family doc. That's often a nice thing to do. And if you have not made contact with your family doctor recently, that's something we always encourage and recommend. Family doctors are, I think, underappreciated in the cancer system, and we sometimes put our heads down, and patients put their heads down, and we kind of get on about the business of treating cancer for a period of months or years or decades. And sometimes family doctors end up dropping out of the mix a little bit, and it's not by intention. It's just because when you've got chemotherapy every 2 or 3 weeks and blood work in between and scans and visits with psychosocial oncology and whatever, it seems like going for your annual checkup is sort of not an important kind of thing. That said, family doctors really like being kept in the mix. I phone family doctors every week to kind of say, hey, I saw this patient of yours and I'm wondering about this, because they often will have many more years of history with you, and they are home care's primary go-to physicians. If you're with a family doctor, it's definitely in your interest to maintain a good relationship there and find out if they're comfortable talking about advanced care planning and symptom management and end of life. And we're happy to co-manage with palliative care, or with community medicine, with family medicine on an ongoing basis as well. So that referral could also come from your family doctor, but the easiest way would be just phone phone up palliative care and say, hey, how do I meet a palliative care nurse and registered nurse as a case coordinator with palliative care will come by your place and assess things.
Thank you so much. And just we're gonna wrap up. Nikki's going to poll. She's gonna launch our poll, and so we want to hear back from you about how we did tonight. In the chats, tell us about other topics that you'd love us to bring forward going forward. As I mentioned, we're going to email a list of resources that we've talked about tonight, so you're going to have that in your email tomorrow morning. A huge thank you to our speakers again. If you are looking at the poll on your iPhone, sometimes it's just a green little statement at the top of your iPhone. To launch the poll, you actually have to click on it. But this information will be really helpful for us to learn more about you and how we did. So I want to thank everybody for joining us this evening, especially to our speakers for making this time with all of us. And have a wonderful, wonderful evening. And we hope to put on something again soon. And you are welcome, once you've completed the poll, with many thanks, to leave the program, and that's usually a red button on your screen that says leave.
Thank you very much, Sheena, and your whole crew there.
Yeah, everyone's saying thank you, guys. There's also a note, I just want to put in a plug for psychosocial oncology and spiritual care in Edmonton and the smaller community cancer centers. The counseling staff are providers of palliative care with the exception of medical care throughout time, from diagnosis of advanced cancer all the way through end of life. Thank you, Lisa. I learned so much. Thank you, Lyle and Kevin from Nancy. Lots of thanks in the chat. Thanks so much for sharing your knowledge, expertise, and time. The poll usually takes just a minute or two. I think there's 8-ish questions. There is 10. Thank you so much for normalizing the need for psychosocial and for clarifying palliative care. Loved the presentation. Thank you to everybody for completing our poll. Really appreciate it. We love your feedback.